Good evening. Thank you for the kind words, ma'am. So, the topic for the day, which was given to me by Dr. Prabhu, was monitoring sperm optimization before ART, and I did not have a clear idea of what to do, but he guided me on the things which I should talk on. So, let's start with the general introduction. As we all know, infertility is a relatively common condition affecting upwards of 50% of couples of reproductive age. The male factors are uniquely responsible for an estimated 30% of couples experiencing difficulty conceiving, and beyond this are a recognized contributor in approximately 50% of all cases of infertility. So why do we need optimization of sperms? Because we have to give a targeted and a high success rate, and we need to produce good quality, healthy sperms. So I think every single speaker has been talking about this word free radicals and ROS. So they are oxygen molecule which contains one or more unpaired electrons in atomic or molecular orbitals. So ROS, which is the radical oxygen species, is a pathology stem from imbalance between the production and scavenging. So I think we have again and again seen this picture. As the previous speakers have already said, ROS is from a lot of factors, and ultimately they result in decreased in the fertility. So what are the uses of antioxidants? So the role of antioxidant is to prevent the oxidative damage or stress. It has an antioxidant defense mechanism, a scavenge ROS, it inactivates, repair, and there are two types, which is enzymatic and non-enzymatic, and this improves the gamete quality and results in spontaneous pregnancy. So signs of oxidative stress in semen analysis is we see a reduction in the sperm parameter, there is DNA fragmentation, hyperviscosity, and there are semen leukocytes which are round cells using peroxidase or seminal electase test. So antioxidants in fertility, why? So as we all know, as Sir told in his first topic, that there is lot of abuse than use. So the antioxidants, they give an oxidative stress, and the imbalance between the production of ROS and there is neutralization. There is cellular damage, excess cause pathological effect, and DNA damage and apoptosis. So oxidative stress results from environmental pollution, smoking, alcohol, poor nutrition, obesity, infection, and chronic and autoimmune diseases. So how do we optimize these sperms? So as we all know, always start with lifestyle modification. Tell the males to have an ideal BMI. You can give them antioxidants. Then if there is a case of any oats, we can go for injectable hormones also, and always correct the correctable causes of infertility. And on the outside, preparation methods for sperm for ART procedures matters, and the recent advances, of course, the microfluid. So role of antioxidants, as the previous speakers have already spoken about, the very main important antioxidants which we focus is the CoQ, L-carnitine, lycopene, and the zinc. So as we all know, the highly recommended CoQ, it is a naturally occurring lipid soluble compound and concentrated in the mitochondrial mid-piece. So it is more towards energy, and it acts as an electron carrier in the mitochondrial respiratory chain. It stabilizes the cell membrane, maintains and promotes sperm motility. And the recommended dose is 50 mg per day. And mechanism, I already told you, it is responsible for the energy of movement and all other energy dependent processes in the cell. And there is any reduction in CoQ will obviously result from asthenozoospermia. L-carnitine, again synthesized in the liver, and main function, it provides energetic substrate for the sperms. Lycopene, again, it possesses a superior ability in comparison to other carotenoids, and it is a single oxygen and it prevents oxidative damage to other molecules. And the recommended dose is 2.5 per day. Zinc again is a micronutrient and lower in infertile men with diminished sperm count. Again the dosage around 12.5 mg per day. So we, in addition to these four, these are the other adjuvants which we give the male partner when they come to us with decreased sperm count or motility. So coming to the medical management in male infertility, now we have started treating male infertility with the hormones also. So GnRH, HCG, HMG, recombinant FSH, dopamine agonist, aromatase inhibitors, selective estrogen receptor modulators are being used. So GnRH, again the main indication is for hypogonadotrophic hypogonadism, Kallmann syndrome and idiopathic hypogonadism. So it is basically a pulsatile release of GnRH in the hypothalamus which stimulates the release of FSH and LH from the anterior pituitary, and the dose we normally recommend is around 5 to 20 mcg every 1 to 2 hours by a subcutaneous pump or a needle. This induces spermatogenesis as early as 4 months of starting the therapy. And of course the disadvantage is it is limited by its availability. There is inconvenience of delivering by carrying a pump, and we need to regularly change the subcutaneous needle. Coming to the gonadotrophins, again pituitary insufficiency. Initially HCG is used alone. After several months of treatment, if no sperm is detected but adequate serum testosterone is achieved, then we start FSH. And the dose we start is 75 to 150 FSH or HMG 2 to 3 times weekly with 1500 to 2500 international of HCG twice weekly. Subcutaneous dose, and the duration varies from 6 to 24 months, and we can continue till we see the sperm in the ejaculate or pregnancy achieved. Coming to the dopamine agonist, mainly the indication being hyperprolactinemia, because the elevated prolactin inhibits the pulsatile secretion of GnRH, and the commonly used drugs are bromocriptine and cabergoline, but we mostly prefer cabergoline because of its high efficacy and the dose varying from 0.125 to 1 mg twice weekly. Aromatase inhibitor therapy is now on the trend, and mostly with men with idiopathic oats or azoospermia. So either we start with anastrozole 1 mg daily or letrozole 2.5 mg daily. So this increases the testosterone, decreases the estrogen level and inhibits the metabolism of testosterone. So the intention is to reduce the estrogenic effect on the spermatogenesis. High levels of estrogen impairs proper spermatogenesis, and this leads to negative feedback inhibition of the HPG axis. Coming to the selective estrogen receptor modulators, mainly used in hypogonadal men, and it acts on the estrogen receptors as agonist or antagonist. Widely used drugs being clomiphene citrate, tamoxifen and taurinephen. So CC has a positive effect on the serum testosterone. So optimizing surgical sperm extraction with hormonal manipulation. So we can use medical therapy to optimize the surgical sperm extraction, which is based on the concept that spermatogenesis is dependent on high levels of intratesticular testosterone and FSH stimulation of the Sertoli cell. So since 60 to 70% of males with non-obstructive azoospermia have a focal spermatogenesis, the optimization of hormonal profile in certain patients are beneficial. So when we use CC, aromatase inhibitor or gonadotrophin, it has a beneficial effect by increasing the intratesticular T levels and normalizing the estrogen levels prior to sperm retrieval. So the use of gonadotrophins to optimize sperm extraction is again controversial, and there might or might not be any sperm retrieved. So how do we optimize the sperms in the lab? By improvising our sperm preparation methods, and of course the latest in is the microfluids in AART. So coming to the sperm preparation methods, why do we use sperm preparation methods? Is to have a yield on the final preparation which should contain a high percentage of morphologically normal, motile, free from debris, non-germ cell, and we have to remove the dead spermatozoa. So all the preparation techniques should be quick, easy, cost effective, should isolate as much as motile sperm as possible, eliminate dead spermatozoa and other cells, include leukocytes, bacteria, prostaglandin, lymphocytes, cytokines and infection agent, and it should reduce the number of free oxygen radicals which are generated by both leukocyte present in the sperm and spermatozoa, and most common methods being the washing and centrifugation. So simple wash is if the semen sample is very poor, it mainly removes the seminal plasma from the sperms, can be used in IUI. So in this we add the culture media to the ejaculate after liquefaction, and mixture is centrifuged twice using low centrifugation force and fewer centrifugation steps in order to minimize the damage caused by ROS. So the steps, as we all know, it is to mix the semen well, dilute the entire sperm 1:2 concentration, then transfer the diluted suspension into multiple centrifuge tubes and you centrifuge it at 120 rotation for 5 to 10 minutes. Carefully aspirate, discard the suspension, then carefully aspirate and discard the supernatant. Resuspend the pellet again by gently pipetting, and then we can use that for the whatever procedure we are using. Swim up is used for sample which has a normal count and motility. Again, allow the semen sample to liquefy. Always check the motility and count, and always label the conical tubes with the patient name and ID. Again, you have to incubate the sample at 60, then place the tube at 45 degrees angle to create a large surface area for the sperm to swim up. Then aspirate the media from the upper part of the tube into pre-warm tubes. Then add 5 ml of the media to the sample and centrifuge for 5 minutes at 120 rpm. Aspirate the supernatant but save 0.5 ml of the media to resuspend the pellet. Then again in a MacLeod's chamber, evaluate the percentage of motile and total number of sperm. So this is the pictorial representation of what I told you about swimmer. Then density gradient, again this is used for poor quality semen sample with low motility, low forward progression, a large number of debris, high number of cells, anti-sperm antibody and highly viscous sample. Again this double density, it separates the cells based on their densities, and again the steps being, you have to take the semen sample, then layer 2 ml of the lower density, that is 40% into a conical tube, then put the layer of the higher underneath the upper layer, and then you have to put the 2 ml of the liquefied semen on top of the gradient. Then centrifuge it for 15 minutes at 120 rpm. Then aspirate the the supernatant. Then take the pellet. Then again we can use it. We have to transfer the semen pellet into a newer test tube, and then again resuspend with a 5 ml of sperm wash at 120 rpm for 5 minutes. Then take the pellet, and then we have to do the semen analysis. So this is the representation of a double density gradient and swim up versus double density gradient. Now coming to another factor, that is your retrograde ejaculation, and we have seen that some men, they pass semen into the bladder at ejaculation, which results in aspermia or no apparent ejaculate. So when we take a sample of post-ejaculatory urine, we can see that there are presence of spermatozoa. So pharmacological treatment might or might not be successful to retrieve the sperms from the urine. So alkalization of urine by ingestion of sodium bicarbonate will increase the chance that the spermatozoa passing into the urine will retain its motility character. So in the lab, we asked the man to urinate without completely emptying the bladder, produce an anejaculate by masturbating into a specimen container, then urinate again into a second specimen vessel containing the culture media. Because of large volume of urine may be produced, it is often necessary to centrifuge the specimen by centrifugation at 120 rpm for 5 to 10 minutes. So the retrograde specimen, once concentrated, and the antegrade specimen, if produced, can be most effectively processed using a double density preparation. Then, what if it is an infected sample, and of course the most common being HIV infected semen samples. So if the HIV is present in semen, the viral RNA and proviral DNA can be found free in the seminal plasma and in the non-sperm cell. So as HIV receptors are expressed only by non-sperm cell, a combination of double density followed by a swimmer has been a very effective way in preventing infection in an uninfected partner. So coming to microfluids, this is actually on the rise. This is nothing but a microchip, and it's an organ on chip technology, and this is mostly another name for it is your cell sorter. So this is a slide where you have 4 medias and you keep the semen in a chamber, medias on the other 3. So the motile sperms will swim to chambers 3 and immotile will get collected in D. So we can use the C well and use those sample for further treatment. So take home message is we have to understand the hypothalamo-pituitary axis and the effect of estrogen excess in the treatment and assessment in male infertility. So goal of infertility treatment in all these women is to men is to optimize the LH level, produce more testosterone from the Leydig cell and more FSH levels to stimulate the Sertoli cells and spermatogenesis. Medical management does play a role in yielding pregnancy. Surgical extraction following medical management and hormone therapy have got some benefits. Again, antioxidants, the risk versus benefits, still we have to have so much of studies to prove that, and sperm preparation techniques have their own benefits and aim in giving good success rates. Thank you.
Dr. Gayathri, it was a wonderful presentation.
Thank you, sir.
Regarding you're talking about that HCG, HMG were used for hypo. So patient with severe odds like 1 million and the motility is very low, does it help by HCG and HMG if you give it for
I have personally given, sir, and it does help. Initially I have given HCG, then I have given FSH. I gave only RFSH, urinary highly purified FSH, 75 I started, and after 3 months when I took the repeat sample, it did help.
So you gave HCG first or the
I gave HCG first, then I...
How much was the improvement? It was like you had a drastic...
So it was less, it was around 1 to 2 million, and when I took the 7th sample after 4 months, I think it went up to around 10 million, and there was an improvement.
Same doubt actually. In patients in men without hypo, have you tried giving only HCG?
No, I don't give HCG alone.
Okay.
I give it as a combination.
So you initially give HCG for 3 months, followed by
I gave for 1 month only, and I gave FSH, highly purified FSH. I did not give HMG. I gave highly purified FSH together. That is after 1 month together, and I did a semen analysis after 3 months of giving both together, and I found an improvement. Around 3 to 4 patients I have given.
Use of GnRH pumps.
I have personally not given.
It must be expensive as well, isn't it?
Yeah. And it is very cumbersome for the patient because they can't be changing it every 3 hours. So it is expensive, and I think the availability is also a little less
limited.
Yeah.
please felicitate our speaker of the session. I now request the speaker to felicitate the chairpersons.